A warm good afternoon to one and all. Transfusion Medicine Academic Society presents before you the next session on webinar. Today, I am delighted to invite Dr. Ramesh Bhaskaran, Professor and HOD of Department of Transfusion Medicine, Jubilee Medical College, Thrissur. Dr. Ramesh Bhaskaran is an alumnate of Government Medical College, Aurangabad, Maharashtra. He has previously worked as consultant pathologist in ThyroCare, Mumbai, in Central Reference Laboratory. Subsequently, worked in Yashoda Super Specialty Hospitals, Hyderabad, in Central Diagnostic Laboratory and Component Separation Labs. He has worked extensively in Clinical Research Organization and Clinical Reference Lab in Vimta Laboratories in Hyderabad. He has also worked in various capacities in medical sales and marketing with TransAsia Biomedicals Limited, Mumbai, as scientific advisor to Horiba, India, and Trivitron Diagnostics, Chennai. He has penned scientific publications in medical journals of national and international repute and has been the co-author of book chapter in the Confidential Review of Maternal Deaths 2021 by the Kerala Federation of Obstetrics and Gynecology. His various areas of interest include medico-legal and ethical aspects of transfusion medicine, general administration, and quality control. I welcome you, sir, to introduce the speaker of the day.
Thank you, Akshay. It gives me great pleasure to introduce today's speaker, Dr. Satyam Arora, who's Associate Professor at PGICH Noida, Department of Transfusion Medicine. Dr. Satyam passed his MD and has more than 12 years of experience from PGIMER, Chandigarh. Okay, he has extensively trained in the Department of Hemato-Oncology and Bone Marrow Transplant, thoracic cancer in Cleveland Clinic, USA. And for today's topic, he's the apt person because he's the co-chair of pediatric transfusion subgroup of ISBT, as well as an advanced biotherapy professional by AABB. So I'm sure that his knowledge is going to add a lot of impact onto the today's program. He's awarded with many awards, the earliest being the Dr. Harold Gunson Fellowship by ISBT in Mexico in 2012. Thereafter, the Young Scientist Award by ISTM in 2021. Followed by Narendra S. Bagari Award by ISBTI in 2022. He has many publications to his names in national and international journals of repute. And I welcome you, sir. Over to you. Let's have a wonderful session. This is going to add a lot because transfusion practices, as you know, this is the most transfused group amongst all the transfusion requires. And rather than being evidence-based, it's mostly opinion-based. So I think today's topic will be of great interest to everybody. Thank you. Welcome.
Thank you. Thank you, sir. Thank you for your kind words and introduction. And I would like to thank the organization, the TMAS, for, initiating this great initiative of having regular webinars and, picking up topics which are usually not focused when we go for the proper conferences and meetings. And thank you for giving me an opportunity to share my work on pediatric and neonatal transfusion. And actually very aptly mentioned by you, sir, that the practices in pediatric and neonatology is less of evidence based and more of opinion based. And I think that's one of the best start to the presentation and the best thing, because that is where we started a pediatric specific, we started working and developing a transfusion medicine department at a pediatric specific hospital. And this was something that we faced since beginning, that there was nothing that we could fall back to, we could refer to. There was a lot of work that is being done across the country in many centers, even internationally, but there was nothing documented at how certain specific product modification they need to be done when we are supporting a neonatal and pediatric transfusion. And that is something that gave birth to one of these first studies that I tried to do across our country, where we wanted to study that what is the degree of variation before we come and guide or bring some guidelines to this area. we wanted to understand that what is the gap and what is the variation, and what is commonly done and what is commonly not done. And then from where can we actually proceed in providing a guideline or some reference to various center across the country. So the topic that I will be presenting today is variation in the role of blood centers in supporting neonatal and pediatric transfusion practices in India. And this is something that I've been trying to do for last 6 years now at my institute. And I'm also fortunate to work with some of the groups internationally and both nationally who've been quite aggressive in working in this area. So before I proceed, I would like to acknowledge, there are many people that first of all, my colleagues at my hospital, a lot of fellow transfusion medicine experts across this country who have responded to my surveys, who have responded to my email, messages, calls. I've been troubling them a lot with asking many questions and many shorter deadlines to answer. And finally, Dr. Ruchika Goyal, she is a faculty in United States at Johns Hopkins, and she's working a lot in pediatric and neonatal transfusion. And she helped me, in gaining that expertise, that what is being done internationally and how can we connect to that sitting here in India and try to improve our practices as per the global standards. So as I begin, this is how I have outlined my presentation. I'll just provide you a brief introduction, and then the survey, the first national survey on pediatric transfusion, that was I was fortunate to lead. And then what is the further work? Once the survey was over, it was published, it's available online. What did we do after that? And what are we doing after that? And then what are the future prospects as far as research in pediatric and neonatal transfusion is concerned? So we all know that, pediatric and neonatal age group is very unique as they have a highly immature immune system and metabolic process. They're undergoing continuous development and, including neural development, which is a kind of organ which doesn't go development in adults. It's completely developed by a child by the time the child reaches adulthood. Most heterogeneous group of patient, as in newborn, we need to consider, the mother's sample and the mother samples detail, the antibody and everything. And it is a very heterogeneous group with respect to newer modalities and therapies which have come in, which includes cardiac surgery, liver surgeries, transplants, bone marrow transplants. So there is a lot that has come into this age group, and which makes it more interesting, and it requires more special, interest. And then this is the group of patient which has the maximum post-transfusion lifespan. So if I'm transfusing an adult, going for a hip surgery or for a liver surgery or for a cardiac surgery is around 50, 60, 70. They have a lifespan ranging from 5 years to maybe 15 years. But this is a group of patient, 2-day-old newborn, which probably has a lifespan of next 70 years. And we may be able to, influence the growth, the development of this child based on our transfusion policy. So it's not only adjusting little volumes or just adjusting small or providing small aliquots to these patients. This is a bit more than that. And this is something that we wanted to study, that, what all these centers are doing. So if we see physiology, many of these systems in newborn are not completely developed. A lot of coagulation factors are deficient. Then if you see body size, the total blood volume in a preterm compared to a term, compared to a young toddler, they vary a lot. Sample collection is a big challenge in these patients, that connecting, doing a phlebotomy, collecting an appropriate sample, giving that appropriate sample. At times we require more than one sample, and how that sample is done, especially in ICU setups, can make a lot of difference. Then use of additive solution. Now, this is something that has probably I've received maximum queries as what we are doing in our center and what others are doing across the world. Use of SAGM, PRBCs have been, I think, one of the most discussed topic in newborn transfusion. Then warming of blood, CMV screening, doing compatibility testing, providing aliquots to these patients, and irradiation. So these are just some of the basic scenarios, some of the general scenarios which make transfusion in this group very unique. So this is what I wanted to analyze. And when we keep these things and we apply to various settings of neonatology, hemato-oncology, surgery, and ECMO type life supports, there are a lot of variation which come in. So we wanted to analyze what is being done and some of the basic questions that since beginning we wanted to answer, that what is the most accepted method to do it, which is the most standardized method, what is nationally accepted, what is internationally accepted, does it impact my clinical outcome, and does it impacts the uniformity in the best practices. So these were some of the very basic questions that we wanted to answer. And before we go and do a literature search of finding answer to these questions, we wanted to know what is being done in our country. Where are we? What are the gaps? So we designed one of its first kind of cross-sectional assessment of blood centers across India and aim to capture as well as study the variation in the practices, in these blood centers. And I'm very fortunate that this work has been already published with Transfusion last year, and it's available online, which, for the participants, if they want to read it in more detail. So this study was planned at our institute, PGICH Noida. It was approved by the ethics committee, though this study got delayed by a year because of COVID pandemic. The target was at least to reach 100 blood centers across India with 45 questions. So because of lack of centralized registry, of having all the heads of department of all the blood centers in India, we actually were able to enroll only academically involved centers, since the emails and the WhatsApp numbers of these people were available in various groups, and we were able to connect to them more easily. So this web-based survey was done on SurveyMonkey software, and this was live from 11th of August to 11th of October in 2021. So it took around 2 months. We provided 2 months for the centers to respond to this survey. If somebody had initiated a survey and they were not able to complete it, there were some reminder emails which were sent to these centers. Not all questions had a single response, and a skip logic was used. So if you're not doing one type of product modification, the survey won't ask you questions related to that. So that's why a denominator may vary in some of the responses. So this is what we found. So eventually the survey reached to around 201 blood centers across our country, and it was completely responded with the consent to share their data was by 103 centers. So a response rate of around 51% was seen in our survey, which is fairly decent, as similar surveys in West have shown a reduced response rate. The major response had come from the northern part of the country, as more than 60% of the survey was responded by centers in North India as compared, which was followed by South India, West, then East, and then Central India. Though there were a lot of centers who started a survey, who did it in between, but they were not able to complete. So that is the reason we were not able to enroll them in final outcome analysis. Another important thing that we saw was more than 85% of the centers who were participating in this survey had a more than annual collection of 3,000 units. So they were decent blood center. They were not a very small blood center. And the blood centers supporting the neonatal transfusion was at least seen by more than 87% of the blood centers. So they were the centers who were supporting this age group of patient. Another interesting thing that we wanted to see was, what is the type of setting in which these blood centers were. So nearly 43% of these blood centers were in an academic hospital, and that academic hospital was providing training in neonatology, pediatric medicine, pediatric surgery, and transfusion medicine. So nearly 43% of these centers were providing academic courses in various of these subjects. So we expected them to answer and to know some of the basic details of pediatric and neonatal transfusion. The rest, 24.3% of centers were providing academic courses in all of these subjects except transfusion medicine. And then there were roughly around 30% of centers who were either blood centers in a non-academic hospital, or a storage center, or a standalone blood center. So we were able to have some, some presentation and representation of all type of blood centers in our country. But, 103 blood centers is far, far less than the number of centers that we have. So this is just a brief representation of what these centers are doing. So first of all, before we began our survey, one of our major question was that how do you define these age groups? How do you define a neonate? How do you define a pediatrics age group? And in neonates, if we see fairly more than 80% of both type, academic and non-academic centers, were defining it to less than 28 days or a month. But if you see pediatrics, they had a wide range of variation. There were centers around 30-35% who were saying it, below 18 years, they were defining it at pediatrics. But yes, there were a lot of centers who were defining it at 16 or even at 12 years. So this is very important for us to understand, because when we start interpreting data from these centers, we need to know that from what age are they defining pediatrics, and what type of patients will be, in this age group from 12 to 18 that may have the indication for transfusion. And around 83% of the blood center reported that they use a different policy of transfusing a pediatric patient as compared to an adult patient. Coming to next part, when we begin for a transfusion, we go for first is the pre-transfusion testing. And one of the most important aspect of sampling in neonatology is use of microtainers, and which is the microvacutainers, which is used for the minimum volume of sampling. And we saw that around 58.4% of the blood centers, which is almost the half of them, were using these microtainers. And in part of these 59 centers, there were 16 who were reserving only for special cases. So they were not doing it for all. And 43 were the ones who were sampling all of their newborns with the microtainers. So this is a very important area where we need to have uniform guidelines, since this phlebotomy loss of blood, this iatrogenic loss of blood, accounts for one of the major indication of transfusion of these sick patients, sick newborns admitted in an ICU. And having a uniform policy in that area may just help us reduce unnecessary transfusion in this age group. Coming to next point is use of immunohematology platform. This is good to know that more than 80% of blood centers were using column agglutination tests for providing testing to these type of patients. And rest of the centers were using either conventional tube testing or even solid phase adherence testing. So this shows that the centers that we were able to reach were using this semi-automated or automated platforms of immunohematology testing. Now coming to another very important and very widely discussed topic, and this was, I think, one of the arguments that I had in my center with one of a senior professor, that why do you need a mother sample? Why should I need to send you a mother? And in a lot of areas where you have an outborn NICU, the availability of mother is an issue. The mother is admitted to a different hospital. The newborn is brought to your NICU, and there is always a tussle and ask, and one of the most common reason for delay is asking for mother sample. So we asked that, whether all of these center, they ask for mother sample. So around 53% said that yes, they do ask for it, but they only ask for an RBC transfusion requirement. Whereas the other 41% said that they ask for the mother sample for any type of transfusion required by a neonate. And there were few who said that they don't actually ask for a mother sample. Thankfully, they were very less, around 4.5%. So around 95% of blood centers who were part of this study, they said that they ask for a mother sample. Now, what happens if there is non-availability of mother sample? If the mother is not there, how would a blood bank report, or how would the blood bank provide a top-up transfusion? So maximum people, they said that they just go for an O negative PRBC, which is around 48%, which was followed by the newborn specific group of for transfusion, and not taking in account the blood group of the mother, which is around 39.6. And there were very few who said they can even go with, with an O positive unit. Now, if there is an incompatibility between the mother and the child, and then what are the type of blood groups that are preferred? So, in case of incompatibility, maximum centers, 68.3% of centers, they said they go for a compatible unit, a unit which is compatible both by the mother and the newborn. Rest of them said that, they go for an O always. If there is an incompatibility, they'll go for O. And there were very few who said they'll go for the mother blood group, and very few will say that they go for pure newborn groups. So now this shows that this is a scenario which is very frequently encountered in blood centers if you're supporting a new neonatal ICU or a newborn transfusion. And there is no fixed guideline, and there is a lot of ambiguity even internationally. There is some clarity which has been given by BCSH guideline, but there is a lot of ambiguity in the way they deal with their patients and the way we do it in our country. And this is something which has been there, and we can see that there is a lot of variation how people approach to these case scenarios. Now coming to antibody screen. Now antibody screen or 3-cell panel is becoming very common, and it's it's been offered at a lot of good centers as type and screen policy, where you do an ABO grouping and you do 3-cell panel for all your patients. So do we follow this antibody screening in pre-transfusion testing in a newborn setting? So we wanted to know from our centers that what is their policy. So we asked that do you follow a universal antibody screening? So there was 45% of centers, they said that they follow it both for newborn and for pediatric patients. There were a lot of centers, 42% said that they do not follow this type and screen policy. Then there were few centers who said it that they follow it only for pediatric patients, and there were some centers who said they only follow it for newborn patients. Coming to the in case if they're not providing it to all the patients, do they provide it to mothers who have whose newborn is admitted with them? So similarly, 45% of centers said that they provide antibody screening to all of their mothers whose newborn is admitted. So they have a reason. And there were again 30% who said they don't provide antibody screening policy. And then there was this unique group of 23% centers who said they only provide if there is an indication. So if there is a newborn who's admitted with a DAT positivity, or if there is an RH incompatibility, then only they will do an antibody screening. Then do you provide the RH and KEL matched phenotype unit? So this was again something which is being offered at good centers where they have the RH and KEL phenotype donor units, and they are able to test the recipient and provide a matched unit. And around 49% of the centers, they said that they do provide RH and KEL, but only to a specific selected group of patients in pediatrics. So they were mainly patients who were thalassemics or who were sickle cell, who were patients who wanted to, who require repeated transfusion. And then there were 37% of the centers who said they do not provide this service. Then around 10% said that they provided to all the neonatal and pediatric group. And then there were just 2 centers who said they only provided for the neonatal group. So we can see that even antibody screening, testing for rarer antibodies in the mother, and providing an RH and KEL match unit, it's something which is now standard of care across country, and still there is a lot of variation in practices and their application in pediatrics. So as far as product modification, we wanted to see what type of product these centers are providing, and nearly 89.1, that is 90 out of 101 centers said that they provide leukoreduced components to their newborns. A lot of centers this provide irradiated units, but only if there is a specific indication. So not to all patients, but yes, if there is an indication where it is required for a blood center to provide an irradiated unit, they go for that. CMV negative unit. So this is something which was drastically different than what has been practiced in many countries abroad, that nearly 83 out of 101, that is 82% of centers, they said that they do not request or they do not receive a request for a CMV negative unit. So neither their clinicians nor their pediatricians or neonatologists, they ask for a CMV negative unit. Since we know that CMV is, it's highly prevalent in our donor population, and that is not screened in the blood units that is provided by the blood center. So this was very drastically different from what is being practiced across the world. Another important issue that has always been discussed is what is the age of unit. Should I provide a fresh unit? And if I provide a fresh unit, what is a fresh unit? How do you define a fresh unit? So this we try to ask these centers that what is the age of unit that you would want to provide, and how would you define a fresh? So many centers said that they want to provide a less than 7-day-old unit. Others said, around 31% said that they would want to go for a less than 5-day-old unit. There were few centers who actually said that, whatever is the freshest unit available with us, we use that. And there were very few centers, around 11 out of 101, who said that, we want to use a first in, first out policy. So any age of unit can be provided to a newborn. Coming next to SAGM. Now, this is another thing which is highly debated, that can I use a SAGM suspended red cell in a newborn? If yes, how? If no, why? So we wanted to ask that, do our blood centers, they have inventory of red cell suspended units? So around 97% of the blood center reported that they have a SAGM suspended RBCs on the shelf. So they have these inventories with them. Now, are they able to use it for newborn? So 67% said that they are providing small volume transfusion, top-up transfusion using a SAGM bag. So means most of around 67% of centers, they were comfortable in using a SAGM suspended bag for a newborn small volume top-up transfusion. What happens if there is a large volume transfusion, if you need to provide an exchange transfusion? So around 51% of the blood centers say they remove the SAGM from the RBC to provide support in case of a large volume transfusion. But again, if you're removing SAGM, what is the method of removing SAGM? How do you go ahead and remove SAGM from these cells, as this is being asked routinely from various centers, and there is no specific guidelines or recommendations from anywhere. So most common method which was used was, and which was reported by the centers, were centrifugation, removal of the SAGM, replacement with a compatible FFP. There were some centers who said they spun the bag, they removed the SAGM, and they resuspended them in the normal saline. And there were another small subset of centers who said they do a red cell washing, 3-time normal saline red cell washing before they issue that unit. So we see that for large volume transfusion, we need to remove SAGM. And removing SAGM, the method to remove SAGM or to resuspend these cells and readjust the hematocrit, that is being practiced very variably across our country. Now, another age-old practice is aliquoting. So do you provide pedi bags, small bags, aliquots to your neonatal ICUs or patients? So almost more than 90% of the blood centers said that they provide aliquot. So it's a very common practice. It's a very universal practice. 47% said they provide aliquot to all type of components. So irrespective RBCs, platelets, apheresis platelets, FFP, they provide aliquots to everything. 40 centers said that they provide aliquot exclusively to RBCs in unit transfusion. And 8 centers said that they provide only for RBCs and FFP, since the platelet volume is usually less for them to aliquot. So again, we see that there is a lot of variation what components can be aliquoted or what components can be provided as per aliquoting. Another important issue was dedicated donor unit, where you reserve one unit for one patient and you try to provide all the transfusion to that patient through that unit in order to reduce the donor exposure. And many centers are trying to follow this concept of dedicated donor unit, where they reserve one unit for one newborn to get all the transfusion from. Very interestingly, we thought it was not prevalent, but less than 5% of the blood center do provide these aliquot in syringes. So this was very interesting to see that this practice is still prevalent, and this practice is still available at a lot of centers, where we thought that this is a older or an outdated practice, but still prevalent at some of the places. Now, going for aliquoting. Now, this is a topic which I've been trying to define, to research in a lot of ways. And this is something that I've been working on. What are the strategies of doing aliquoting? So this is another work that is ongoing, where we want to define the aliquots. And we on review of literature, we found that there are broadly 3 strategies that can be adopted. The first strategy is, where if somebody asks you, maybe, based on 10 ml per kg volume requirement, there is a newborn with a 3 kg weight, and with 10 ml per kg, you need to provide 30 ml of blood. So this is strategy 1, based on the ml per kg blood requirement of the newborn. Then there is strategy 2, where you have an aliquot which is of fixed volume and fixed number. So this is a practice which is recommended in UK, where they make aliquots of 45 ml each, and they probably will make 5 aliquots out of 1 PRBC bag. So they know that their bag is quality controlled. It has a fixed amount of volume, fixed amount of hematocrit, and they know how many aliquots are to be prepared from one unit. And the clinician know that 1 aliquot will mean 45 ml. Now, there is another third strategy, is something which we practice at our center, and there are a lot of other centers who do that, is dividing into equal halves. So if I have a 300 ml bag, I'll divide it into 3 equal halves. If I have a 280 ml bag and I want to divide into 4 equal halves, that's maybe it, 70 ml each. So these are broadly 3 different strategies which are there. And we try to understand that, which type of strategy is commonly practiced in our country. So we asked that, do you provide pedi bags or, a la carte? So most of the centers said they do provide pedi bags, on request. Then we asked that, how do you prepare them? Do you use a sterile connecting device? Do you use the blood component bag? So most of the centers said that, 84% said they use a separate bag, which is a separate sterile bag, and they use a sterile connecting device. There were a few centers who said they use unused, component bag, which is available, which is often not, if you're not able to make component in that bag. And there were very few who said they used a penta bag. Then we asked that, how do you provide? So this is the strategy. So most commonly, around 71% of the centers said they provide these components based on the volume asked for. So it's a 40 ml, 60 ml, depending what is asked, they use that. And then, there were centers who provide both on number of unit, volume of unit, and the strategy may vary depending on the center. Another thing that we wanted to ask, and probably there is no data in India, even a lot of centers abroad also, that what is the volume, what is the normal range? So we tried to ask that what is the, average minimum and maximum volume of your a la carte. And we saw that around 30 to 60 ml minimum and 80 to 100 ml maximum. This was a roughly volume that an a la carte may range in between as per 47% of the centers. And it may even go as low as 20 to 30 ml with 22% of centers. And it may also go as high as 80 to 100 ml as maximum 120 to 150 ml in 10% of the centers. So, there is a lot of variation. And I think with Drugs and Cosmetic Act approving an a la carte as an approved blood component modification or type of a blood product, we need to define what are the quality control parameters for these type of product modification, and having a appropriate range will probably be one of the first things to define how an a la carte needs to be prepared and how do we do a QC for that a la carte. So 42.5% of blood centers report they do monthly quality control of the red cells. So since we don't have a criteria to say what is as per quality and what is not as per quality, but still there were 42% of blood centers who were saying that they were doing some kind of quality control, maybe just a culture or maybe some sterility test. Another important aspect was platelet transfusion. So we wanted to know how our centers are preparing platelets. So most of them were preparing it in a Buffy coat method, which says that since they all had SAGM and leukoreduced inventory. And many centers say that they prepare both PRP and Buffy coat method. And there were very few centers who mentioned that they were only preparing PRP based method, or they were only our center is not preparing RTP. There was just one center who said that. So what happens and what is the recommendation of this center when there is an ABO incompatible transfusion requirement? So, and there is non-availability of the compatible or the same blood group unit. So there were 45% of centers, they mentioned that, they recommend use of across ABO transfusion, both in neonatal and pediatric age group. And there were 28% of the blood centers who said that we do not recommend that one should use a cross ABO unit in a pediatric age group. And there were some centers who said we only do it in pediatrics, and there were some centers who said we only do it in neonatology. So this is something becomes very important in the season that we are heading to, dengue and high platelet requirement season, where often we don't have a compatible unit available or the same unit available on shelf. And we do try to provide them with an across ABO compatible or, minor mismatch units where they can be transfused in case of a life-saving scenario. Again, this is something new. PASS has been increasingly being used. So are we able to use PASS? So as this is a new technology or new modality, 80% of centers say that they don't use PASS. And there were few who said they only use in pediatrics. Some said that they use it in both, and there were very few who said they only use it in neonatology. So again, this pass is very new. There is very less data, though now there are more publications which justifies the use and establish the safety profiles. And yes, this has been increasingly being now used at a lot of centers. Now coming to how do these units get transfused? What is the practice in various centers? So we saw that blood warming is not recommended by 40% of centers, whereas 39% of centers say that it can be, they can follow blood warming in specific indications, but using a approved blood warmer. And there were some 20% of centers who said they still recommend doing blood warming for a neonatal transfusion. Going across ABO, as discussed, nearly 71% of centers say that they recommend use of across ABO compatible units for red cells and platelets, and 54% said they recommend it for FFP use. So now coming to what the whole survey was and what did we learn from it and where are we heading it further. So presently there are more than 4,000 blood centers in India, and this survey was only able to reach roughly 5% of them. And 2.5% of them actually responded to this survey. So this is very less, and this is, I think, hardly tip of an iceberg of variation that can happen across our country. So the response rate was good. We still had some wide representation as we had centers from across the country. And they were mostly academic centers. So this is something good, that if again an academic center is following an appropriate guideline, or if they have defined guidelines, they may be training more people in it, and that guideline may penetrate in deep and periphery. And they were mainly the centers who were providing pediatric and neonatal transfusion support. So we were anyways targeting these centers, and we hope that we reach them and we are able to identify the variations. So we highlighted that there is heterogeneity in the practices, and one of the main reasons of lack of this heterogeneity is lack of any specific pediatric and neonatal national guidelines and transfusion recommendations. So there are some recommendations by certain groups like NNF, and there are a few more, but there is lack of any uniform guideline as far as product modification from blood center is required, that how a blood center should approach to doing these product modification and supporting these patients. Aliquoting is an age-old process, and very recently it has been mentioned in the Drugs and Cosmetic Act. So now people can actually follow that. And, but we still don't have quality control parameters and other specific established criteria to provide quality assurance of providing even these aliquots in our group of patients. Yes, we did had some limitations, and we hope to work on them as we go ahead. One is, as rightly, many of you might have identified, it's a very small fraction, very few blood centers, that too only academic centers. And we, this does not actually reflect what is actually happening across this country in periphery, but yes, this is what is happening in various academic and good centers. And we hope that policies from that center gets adapted in the periphery of that region. And they were majorly large hospitals which participated, and they were good academic hospitals. So they are better funded, better managed. They have transfusion medicine trained person and physicians. So thus the center can operate these sophistications and advances. Whereas we know that a district level hospital or a standalone blood center may not be able to practice all these things. Some of the advances like pathogen reduction were not assessed in the survey, since they are not practiced at present. This survey did not study variations in the advanced treatment, such as if the patient is requiring a hematopoietic stem cell transplant, cardiac surgery, ECMO, solid organ. So the variation, the more variation that will come, in these type of practices and these scenarios were not assessed. So finally, to conclude, as far as this survey was concerned, that this is the first detailed survey-based cross-sectional study providing a snapshot of what is happening across this country. And this highlights the variation in various steps, requirement of model sample, additive solution, aliquoting, product modification, quality control parameter, and even transfusion procedure. So there are some variation at all the steps. This survey provides a baseline of the practices in India. So this actually gives us one baseline to work upon, as well as it highlights some research opportunities in defining the practices in this area where maybe centers or region can work and define some of the quality parameters for us to define the transfusion therapies in this patient. Now, coming to further work, as I was fortunate that my proposal was accepted to do this work internationally by ISBT and VOX, and we were able to conduct the international forum, the first international forum on small volume transfusion. So we wanted to understand that this is what is being done in India, now what is being done across the world. And we were happy that all major centers across the world were participated in this study, and they responded to our survey. And we were able to find that there is global heterogeneity as far as these practices are concerned. So I will not be taking in detail these two international forums, as this is not part of my presentation, but I'll just walk you through some of the major variations that we were able to identify. So if you see, the first question was regarding the CMV testing, which has a huge impact. And there were few centers like Israel who provide, CMV tested blood to all of their newborns. Then there were centers like Canada, Italy, Netherlands, and UK who provided to a selected group of patients. We went in deep. What is the selected group? So Canada provides it for IUT. Italy provides for all newborns and infants and pediatric hem-onc cases. Netherlands goes for IUT and some further selected indication. And UK provided for all of their newborns. And then there were centers, majority of centers, they said that they don't do it, like Argentina, Brazil, India, Malaysia, Oman, Singapore, South Africa, and Uganda. And there were few centers who said, we provide leukoreduced unit, like Saudi Arabia and US. And they said, since, it's leukoreduced, they don't need to test for it. And there were some centers who, like Spain, who did not provide any information on that. As far as pathogen reduction was concerned, it is largely not available in most of the countries, but technology is available in centers in Netherlands and UK, but they do not provide it to infants. Whereas the technology is available and they provide it to newborn is from Italy, Saudi Arabia, and US. And depending on what type of this pathogen reduction technology they have been using, there was a variation. So we see that there is a lot of variation across the country, as well as far as the policy for supporting these patients. As far as we see aliquot preparation, so all aliquots are pre-prepared in places like Israel, Netherlands, South Africa, Spain, Uganda, where they have it on shelf. But there were a lot of centers who prepare aliquots only when they receive a request, like Argentina, Brazil, Italy, Oman, Saudi Arabia, and US. And they have both. There are centers who have both type of inventory. They have available and they can make new as well. So that was there in Canada, India, Malaysia, and Singapore, and UK. So, there were very few centers who had, a standard way of making it, like Israel, Malaysia, Netherlands, Singapore, South Africa, Spain, Uganda, and UK. Whereas rest of the countries, they make it, as per they receive a request. Another important thing that we wanted to ask, that do you add any discard volume, or the volume that you may want to just add it for the BT set or for your IV set? So there were only few centers like from Argentina, Brazil, Italy, Oman, and US, where they provide some additional dead volume. Then aliquots are prepared from dedicated unit. This was also not uniformly practiced, and there was a variation in the way these countries were practicing these policies. So we see that it's not only in India, we are not very far behind, but the variation is there across the world. So there is a need to do research in the field of pediatric and neonatal transfusion practices. This is the most, as one of the most, we still have adaptation from the adult practice. There is less and very few data, as rightly mentioned by the chairperson, that it is more of opinion than of the evidence. And this is a transfusion which is in high number. And I was surprised to see the WHO says that in low income country, up to 54% of transfusions are given to children of less than 5 years. So now this becomes a big number. This becomes a big area to work upon and to see that what can be best practices to provide transfusion in this age group of patients. So as far as the area of research, need of research, variables, so there are n number of variables that has been defined when we are transfusing a newborn, right from donor, gender, age, CMV status, the expiry of the unit, storage. Are you able to do a volume reduction? What type of aliquoting? Did you use a bag? Did you use a syringe? Did you wash these units? What was the age of irradiation? What was the patient characteristics? And did you do it inside, offside? You're doing irradiation from some other center, or your blood center is doing irradiation. So there are a lot of variations. And, these variations are adding each year since we are going into more advanced therapies for these age group of patients. So this is just very small brief, on the areas where you can work and research is the transfusion strategies, that what is an optimal transfusion strategy to transfuse any of these patients depending on the clinical scenario. What is the effect of age of this unit? Some of the short-term and long-term research topics are pediatric hemovigilance, which is still there are a lot of gaps in the evidence for pediatric hemovigilance. Then transfusion-related gut injury, which is also known as necrotizing enterocolitis in preterm newborns, that has been hypothesized and associated with a transfusion. RBC aluminization, which is more in the pediatric age group once we start having thalassemics and sickles. And then the role of microchimerism when you are repeatedly transfusing an adult RBC to a newborn. Then TTI, blood safety, I think is more important and most important for pediatrics, as there is a longer lifespan. And the role of CMV screening, it has been done in West. What is the strategy? Should we do it? Should we not do it? Since all our donors are positive for CMV, it doesn't actually make sense for us to test. Then role of pathogen reduction. So that is coming in next. And are we able to define and use them safely for our pediatric age group? So we know that there is lack of baseline database for retrospective longitudinal studies in neonates to young adult who receive blood products. There is a need for novel in vitro, in vivo model to study these impact of transfusion guidelines in specific diseases and conditions. There is lack of randomized trials which evaluate, the outcome of these patients who receive these blood products. And now, cell therapy and transplant is just outside our door, knocking our doors. How will we adapt, for cell therapy in pediatric and neonatal age group? So for further work, there is a need for India-specific data, which is highly lacking. There is a lot of data which is there at institutional level, but national level data is lacking. We are still not able to answer some of the questions like what is the scope of work in pediatric and neonatal transfusion in India? Which type of patient require more transfusion? Does the indication and need vary depending on the age of pediatric age group or gender? And what is the status on newer modalities like ECMO, transplants, and the liver and cardiac surgery? So we don't have any baseline data. And this is actually something which gave us the question for our next research study. And I'm happy to share that we started this study in 2021, where we wanted just to understand that what is the indication of transfusion in pediatrics and neonatal age group in India. And we started this study in 2021. And the mnemonic which we were able to give to this study was ITBP-IN, which is the indication for transfusion of blood and blood components in pediatric and neonatal age group of patients in India. We are happy that the 23 medical colleges across the country agreed to participate with us. They were, we are thankful that they agreed to share their data with us. And the data submission is complete, and we have more than 50,000 pediatric blood requests from these medical colleges. And at present, the data analysis of this another study is ongoing, and we hope to publish the results by end of this year. And this probably be one of the first, evidence-based or first data-based, guideline or database evidence on pediatric transfusion from our country. Finally, to conclude, India is now one of the most populated country in the world, as well as one of the most youngest nations. We probably has maximum number of pediatric patients in the world. Transfusion is commonly offered to these patients, and we need to develop some indigenous guidelines. And there is a need to define pediatric and neonatal transfusion best practices in India. So, we are able to provide good transfusion support and safe transfusion support. And with my little experience and interaction with international, arena in this field, even there are a lot of issues in the West that are not also defined. So this is a good area where we can work, where we can lead, and we can show that, what are the best practices. Finally, thank you. Thank you for giving me an opportunity to present, and I'll be happy to take questions. You can, email to me, or you can follow it on Twitter. I don't know from today onward whether Twitter is a bird or an X. I don't know. Elon Musk has done some good changes. I hope they are good. And I just want to leave you with this thought, which I read few days back on an online social media platform, and which kind of stuck with me, that either write something worth reading or do something worth writing. And I think in India, we have a lot of potential to do some good work as far as pediatric and neonatal transfusions are concerned. And we are always happy to collaborate, associate, and work together on it. Thank you.
Thank you, Dr. Satyam. It was really a wonderful talk. The data which you provided, the most important thing is your response rate, 50%, I think 51%. Because in a similar study by Reeves, as early as 2021, their response rates were hardly 15%, and they have not covered much of the things which you have covered here in terms of the questionnaire which you prepared. So I think it'll add, and as you said rightly, we need more focused research, more randomized trials, and it's a good area for the young transfusion medicine specialists to take up in their own individual working setups, to add more value to this, and to come up with maybe institutional guidelines or something which can be collaborated, and coming up with some national guidelines on pediatric and neonatal transfusion. So I think it was amazing work and a very nice presentation. I think a lot of people will have questions regarding the policies which they follow or you are following in your institute. So now it's open for questions. Those who want to answer, they can kindly question this. Okay, we have those who want to question, they can unmute themselves, and they can directly ask Dr. Satyam.
Good afternoon, everyone. This is Dr. Charu here. And Satyam sir, this was a wonderful talk, quite inspiring about the work that you have shared with us. And my question would be on the dedicated donor unit. So I wanted to know if you do practice that, where you cross-match one unit and then keep the unit in stock for the particular newborn. So if we are going to do that, what is the timeline? Like, does that unit stay even after the newborn is discharged, let's say? So do we take it back to the inventory, or is it taken as, even if one aliquot has been issued from that said unit, what do we do with it? So what is the practice that you follow?
Yeah, so thank you. So this is actually a very interesting topic, and this was my thesis topic from PGI Chandigarh.
Okay.
So we have published one work on use of dedicated units in pediatric surgeries patients. So there are three things I think which you need to define before you go ahead on it. First is, are you, you're able to follow FIFO, because your this dedicated units, maybe the second or the third aliquot may land up at an age of 25 days, 30 days. So this is something that you need to define, with your patient group that you want to support, that are you able to go for FIFO? The another thing is, once you are able to define, suppose you're able to use an older unit, the way we practiced was, we kept it till the patient was admitted with us, and or till the patient were expected to receive a transfusion. If there was another newborn who required the same blood group, we would want to issue it to that patient as well. We will not recommend holding that unit for expecting that the patient might get readmitted, because that is very unpredictable, and that will lead either to discard of that unit, or maybe, using that unit at an age of 36, 37 days of age. So we try doing that, but if you have patients who are receiving a lot of transfusion in a lot of gap, there may be preterm who going for surgeries like intussusception or some other surgery. So there are good target patients for whom you can keep. And even dedicated donor units can be not only done for RBC, it can be done for other unit as well, like platelets and other components like platelets and FFP, to further reduce the risk of donor exposure.
Thank you, sir. My query about the answer you provided is that holding the unit in order to minimize the donor exposure, the risk that we are trying to avoid by this, does it outweigh the risk of giving an aged unit?
So that is what I said for the first thing, was you need to define and confirm with your clinicians that you will be using in a FIFO policy. A unit of whatever age will get issued to a newborn. It need not be a less than 7 days age or less than 10 days of age. So once you're able to define that with your clinician, you may be able to use that unit even till a later age. And now with the newer evidence, the age has not actually been shown to too much of an effect in the outcome. But yes, a lot of studies which have done on this part of age, they've not used blood units of more than maybe 20 days of age. So we still don't know on a long-term outcome, an age of 30, 35, will that impact these patients? But yes, in our center, we use aliquot.
Thank you, sir.
So there is, I think, one question in the chat box, which is the aliquot irradiated or the mother bag? So, so it depends on 2-3 factors. One is whether the irradiator is there in your blood center, in your hospital, or you're getting it done from outside. Second issue is what is the indication for providing an irradiated unit? Do you expect there are multiple units that will go to this patient, or just one odd transfusion? So that will define if you can do it in-house, why you can do it each aliquot. If you're getting it done from outside, you can get the mother unit irradiated. And if you expect more number of transfusion to go to this patient, suppose a newborn who's come after an IUT and may require 2-3 top-up transfusions, you can get the mother bag irradiated. So that can be followed.
Yeah,
Any
you
other
can kindly unmute yourself and ask more questions, or you can put it in the chat box also. Okay, I think there's one question in the chat box from Dr. Nitya Mohan. Shall I read it out?
Yes, sir, please. I can't.
Yeah. Please opine out on the group platelet transfusion for neonates. Can it be given? Out of group platelet transfusion for neonates. And in this scenario, if a neonate is AB negative and he requires platelets, will you go for O negative or AB positive as the first choice? O not being a universal group for plasmas.
Yeah, so going across ABO transfusion, there are few published data which supports that you can go ahead, use across ABO. There have been a PPT3 study, which was a multicentric study of a lot of pediatric ICUs and neonatal ICUs across the world. And in our 2 centers from our country did also participate in that. And that study says that there is no significant difference in the outcome and transfusion reactions if you go ahead and use a ABO incompatible platelets in pediatrics. Now, said and done with that, there is a recent READ-SPE data which has come up from United States, which says that except in 2 subgroups, rest all pediatric neonatal age group is okay to use an ABO incompatible unit. And that though 2 subgroups that they have defined is hemato-oncology and intracranial bleeds. So they say that since hemato-oncology patients will end up receiving a lot of back-to-back transfusions, so there is always a chance of platelet refractiveness when you use an EBO-incompatible platelet unit. Apart from that, as far as the case that you said, I would recommend going for an AB unit first. Since the recipient is negative, I would ensure that my RDPs are not red cell contaminated. So I'm not exposing these units with a D antigen. And as far as the policy that we follow in our hospitals, we do not label for D on our platelet and plasma products, since they're not expected to have RBCs and they don't have a D antigen on it. So the units that we use are can be used based on, they can, a D positive unit can go to a D negative patient. And our first choice will be to go for an AB unit, since it does not have any antibody. And then depending if the recipient is O, we'll go for B and then A, and accordingly that. I hope I answer her question.
I think she's okay with that. She said, thank you very much. So that's a nice explanation for her. Probably helps her out. Anybody in the, you can always see, so Dr. Satyam has given his email also. And like you said, whether Twitter is Twitter or not, or you can follow him there and you can probably post your questions there also. You can email him also. So that is one other way. But here it would be great if you can ask some more, questions. If anybody is there, unmute yourself and can directly ask. I don't see any more questions in the chat box. All right, so I think you'll get a lot of emails, Dr. Satyam. So probably you can
I'll be happy to
them,
answer.
in much detail there. Thank you for such a wonderful talk.
I think there is one more question, sir. Sir, there is one more question from Dr. Sneha. She's just written it on the chat box. Is the slightly off topic, sir. TP in pediatric patient have allergic rashes. So see, allergic, as far as transfusion, pediatric hemovigilance is concerned, all the data that has been published across the world, they've seen that allergic reactions are more common in pediatric age group. And if I'm not wrong, even the shots and the national hemovigilance data of our country also supports that, that there is a higher risk of an allergic reaction, especially when you're using the platelet-based product, the plasma-based products. The hypothesis that has come is that their immune system is more responsive to the foreign protein particles. And, that is, as far as our next question is, what do we do apart from AVIL? So, see, AVIL is a symptomatic treatment when you have a reaction. In case of TP, we would recommend if there is no absolute indication to use FFP, go for albumin as a replacement fluid. Yes, there are indications like TTP and some other where you would need to use FFP, and you'll need to be prepared to manage these reactions. And it's always recommended to use the albumin-based replacement products. Another question is from Dr. Prateek. He says the reconstitution of a whole blood for an exchange transfusion. Are there any standard guidelines in addition of an AB FFP in terms of volume and volume of the hematocrit? So see, a lot will depend what is the ABO incompatibility between the mother and the child, and if the newborn, if there is an absolute or major incompatibility where you have an O mother and A or B child, in those cases, we would recommend use of an O negative PRBC with an AB plasma. Now, adjustment of hematocrit, there is a specific formula for that. If you want, I can share you that. So, the way is that we target preparing a 50% hematocrit bag for an exchange transfusion. There are some neonatal guidelines who also say prepare 40% or prepare 60%. So this is something that you can discuss with your neonatologist, that what kind of hematocrit are they targeting. And a higher hematocrit is usually recommended for if you're preparing for a bag which is for an IUT. So, yeah, reconstitution is practiced, and it is probably the safer way of providing reconstituted whole blood for an exchange transfusion. I think I answered to them, sir. I hope there is no question on your chat box.
There's nothing on mine, Dr. Satyam. So I think maybe the other questions can come into your mail, and you can
Sure.
take time to
Sure,
solve
sir.
more. Thank you so much. It's been a
Thank you,
wonderful
sir.
session. Thank you for answering all the
Thank you.
queries, and we hope to have you again with your next part of the study, with your, the results when they come out. So thank you so much.
Sure, sir.
Uh,
Thank you, sir. Thank you for the opportunity, sir. Thank you.
Thank you, Dr. Satyam. It was indeed a very informative class, and we are hoping to meet you soon with TMAS. Before I wind up, I would like to remind you that on August 10th, we will be again coming with our next episode of Clinical Club, where Dr. Nitya Mohanan and Dr. Anshika Yadav will be talking about their cases. So until then, it's a goodbye from Transfusion Medicine Academic Society. Thank you.